All right, and welcome to the September. Yeah, I know it's October. I can kind of tell time sometimes, but it is the September version of Why Does Healthcare Suck? And we are going to jump into a very, very important subject today. We're going to give just a couple of minutes for people to jump on board because we know that this is a very important topic. A lot of folks have really made really inroads in this, but then man, there is so far to go, and there's so much I think miscommunication in some cases, and then misunderstanding of what navigation is. Uh, people just get in their mind an HMO, and then they're like, yeah, I don't want nobody telling me what I can do and what I can't do, and they get down in that place, and then they think that that's what we're talking about when we talk about navigation, and we're going to really bring some light on that today. Before we get started, I do want to because I know sometimes people get just really pressed for time near the end of these. We try to keep them right at an hour, but I do want to remind everyone that we are going to, due to popular demand, we are going to do what was the favorite show in 2023. We're going to have part two of it here in 2024. It will be on a special day, the 31st of October. That's right, Halloween. And we're going to do a Why Does Healthcare Suck? Healthcare Horror Stories. It was our number one show by far last year, where people came on and actually told about experiences that they had to help others avoid some of those healthcare horror stories. So I really want to point out that we're going to do that, and we're going to totally do a different thing. We're going to go back to the old way and do an audio event. It's very difficult to get people to get up on the stage in this. It's not near as easy to bring someone up on the fly. So we're going to do a LinkedIn live audio event on the 31st, 11 a.m. Central Time, Healthcare Horror Stories. We will point that out to you again at the end of this show, but we're really excited about that, and we hope everyone can join us. And yes, hello, Emma Fox, giving us a big hey. Appreciate you being here. All right, so let's jump into today's topic, which is care navigation. It has, in many cases, I think, got a bad name because people equate that to I've got to go through my gatekeeper doctor. It's an HMO. They're going to send me all these places. Or they think of it like people get lost in a healthcare system right now, and they just keep rolling through. They just keep sending you to the next specialist and the next specialist, or a handful of specialists. They say, hey, look, you got three things. And I get to refer you to three different people. Woohoo! Bonus for me. It's not the same thing. I'm going to touch on a number of different things today. But the first thing I want to do is introduce you guys to my buddy, Nick Soman with Decent Health. Decent. I mean, you guys are better than decent. I know, man. You're rocking it out there, and you're bringing the biggest part. That, man, whenever I found out what you guys were doing, of course, we just had to work together, and then I had to have you on here because you're building everything around direct primary care where it should be to begin with, because care navigation should always begin with your primary care provider, and direct primary care is designed perfectly for that. Welcome aboard, Nick. Thank you so much for agreeing to be with me today, buddy.
Thank you, Harlan. I think the world of you and of Kelly, and we exclusively sell through brokers at Decent. We're very long and pro brokers because there are brokers in the world like you that I know are trying to help people solve this problem. I sincerely believe that direct primary care will eventually be called primary care, and I think together we're building the future of healthcare, and we're certainly starting to see it in some of the growth over at Decent. So if I look a little tired, I look a little chubby, well, I always look that way. But it's especially right now because we're really starting to go.
Well, I got some bad news for you. Today's the first day of the fourth quarter. If you're tired now, See, I knew if I didn't catch you now, brother, it was going to be real tough to catch you after this.
Hey, we're all good. I can run on adrenaline for about 3 months, Harlan, and I got about 3 months in me. And yeah, let's go. We've been planning this for 7 years.
There you go. Yay, man. And it is, you're hitting the ground running. We're really excited about the groups that we are going to be putting with Decent. I mean, we are super excited about that. And I'll tell you what is interesting to me is having the conversations that we've had with some of these groups and how accepting they were of care navigation and the thought of what care navigation is going to be. And the number one reason I believe is because when you explain it to what it really is and what it's bringing to the table, it changes things. And I think the biggest part, the number one thing that we stress when we talk about care navigation is the personalized patient support that this individual gets. Because it's the same thing. We hear this over and all talked about different things. You've seen one DPC, you've seen one DPC, but it's also the same with patient. You've seen one patient with diabetes. You've seen one patient with diabetes. It is not the same navigation pathway for each and every person. And so that personalized patient support is just paramount in how these things must be built. So talk a little bit about what y'all's look at that is and how y'all are able to accomplish that.
I will. And actually, I've been playing with an analogy that I kind of like because I think it points a little fun at this system and at the solutions we're trying to build. Harlan, I want you to imagine that you're an average everyday American, and one day somebody let you into a pharmacy and they said, Harlan, you're on the special PPO pharmacy plan. And the good news for you is you can take any drug you want. Now, it's going to be a little bit expensive, but you can take any drug you want. And you might say, well, gosh, I guess I kind of like that idea of I can take any drug I want. Which drug should I take? And they say, well, you could look on the internet for that. And you say, well, could I talk to someone who's an expert on the drugs? And they said, well, it's going to take 38 days on average for you to go in and see the drug expert. But, for that 38 days, you're in here. You can go wherever you want. You can take all the pills. And you would look at that and you'd say, that doesn't really feel good to me. And that's kind of what our PPO system looks like right now. You can go wherever you want, but you need somebody who you trust to tell you where to go. I'm looking at Robert Pfeiffer. He's making a comment. DPC should be step one. It makes everything else work better. Yes, that's right. I'm Nick Soman. I'm the CEO of Decent. We build health plans around direct primary care. All of our health plans, 100% of them, are built around direct primary care. And why do we do that? Well, personally, I do that because I'm the child of 2 primary care doctors. I'm the only one in my family who's not a primary care doctor. So the joke I like is no matter how this podcast goes, I'm already a disappointment. But, I grew up watching my parents get frustrated with the rise of big insurance companies getting in the way of patient care. I couldn't agree more with Robert Pfeiffer. DPC ought to be step one. What we know that not everybody else knows yet, but Harlan, I know, and you and Kelly know this. I know Emma Fox knows this. I know a lot of people listening here know this. When you put DPC in a health plan the right way, even though the DPC costs money and the health plan costs money, put them together right and it costs less money. And as soon as we figured that out, we really started to grow. So that's where we are today. Coming back to care navigation, people want care navigation, or what I would call care management, from somebody that understands the system.
Right.
So we asked the DPC to be the quarterback for care. It's the best pitch I've gotten to give in my 44 years of life. I go to the DPC and I say, can we send you members? And they say, yes. Who are you? And then I say, well, we run Decent, and all you got to do is take care of them. And when they need care outside of that primary care setting, we'll help you figure out where they should go. And that's it. And it works real good. We've got a tremendous nurse care navigator on our team named Julia. And Julia helps make sure with her team that people do what the doctor or the clinician wants them to do. And it works really well because you have a chance with direct primary care to build that trust with a clinician, a doctor, a nurse practitioner, because we support those two. And that really makes all the difference.
No, you're exactly right. And, there's so many barriers that people have too, right? Some those barriers to getting quality health care can go across multiple different ways. And this is another thing that a navigator can help you get past. We've talked with folks that their barrier was as simple as language. And while that sounds like, well, what do you mean simple as? Well, it's simple as because, there are people out there that can help you with this, but not many times in a traditional health plan because you don't even know who to ask or where to ask them. And it can be very difficult if you don't have someone to work through that. But I think one of the biggest constraints that we see in people getting the care that they need is financial. In a traditional health plan, you may get the best advice as far as go and see this doctor or you need to have this surgery or you need to have this type of image. But when you have a $9,000 deductible, like is in many ACA plans, or even a $1,500 deductible that is pretty common in regular employer plans, that is a financial barrier that many people cannot overcome. We see it all the time. I know that you've seen it too, Nick, because in your plan design, based on that DPC's navigation and advice, you've done something very, very innovative. So talk about what you guys have done to address, in particular, the financial barriers that so many people have run into.
I have a dear friend named Hari Sundram, who is the founder of Verikai. He now is building a company called Rightwise. Hari and I nerd out about how to fix what's broken in healthcare. He's a bit of a mad scientist. He always says the same thing, Harlan. He says, you have to make it profitable to do the right thing. And that's really a lesson that we have taken to heart in the Decent plans. If you go to preferred care, whether you get there through your DPC, you get there by calling us at 1-888-DECENT9, or you use some of the self-serve tools we're rolling out, all of that care is $0 out of pocket to the member. We make it absolutely free to do the right thing on our plans. And that also goes for medication. If it's a covered medication and you work with us and our transparent PBM disclosed RX, you say if you play the game, then your meds are also going to be free. It has to be dead simple and profitable to do the right thing. So we really try to make that happen on Decent plans.
And that just makes sense. I mean, it really does. When you start understanding that the whole plan is built around the patient and looking at the patient's needs and removing all the barriers to healthcare, why wouldn't you want to make sure that they get the proper advice, but don't have anything in the way to get the proper treatment, to go to the proper place?
That's right. And I want to just share some math with you, because this is the thing that blew my mind. I was afraid that we would be able to build a health plan around direct primary care, but all we could ever be was a premium plan. And I'm not knocking premium plans. It's great to have high cost options out there that offer great service and care. I'm just not interested. We as a company are trying to make healthcare affordable for people, not make something that's better and costs more. And so what we figured out, and this blew my mind, is that you can really save money in a plan built around direct primary care because of the direct primary care for just a few reasons. The first one is that direct primary care can often handle about 82% of the medical needs. And I'm actually going to give a shout out to Emma and to David Contorno because they have been front and center in helping drive some of this research. In a large group health plan built around direct primary care, about 82% of members will not have a medical care need that they need to go outside of the DPC's office for in the course of a year. That's a tremendous number. That means, not a math guy, I get the numerator and the denominator mixed up, but I'm pretty sure what you just did there is you said that you're not having to worry about a big chunk of 82% of members for that care outside the office. The DPC cost, which is going to be $70 to $90 a month typically, is going to pay for itself just on that. But then you add in these two things. My friend Fritz Bush over at Milliman has done a bunch of research with the Society of Actuaries to show that when people get unlimited access to a physician, like in the DPC model, they have fewer downstream costs. They have less ER admissions. They're healthier. I mean, shoot, I'll give a shout out to one of my DPC docs. I got a couple of them now. Dr. Sam Kamar. A few years ago, Sam said, Nick, you're getting a little chubby. And when I picked my chin off the floor, I said, well, what a great relationship that I have with this doc, that he can tell me that I'll listen, and that we got the next 45 minutes to figure out what we're going to do about it. It really helped me out. It reduces costs down the line. And then the last bit, and Harlan, this one drove me nuts. I went and I looked at our math from a preferred partner I love, Employers Health Network, out in Austin, Texas. They've got a tremendous amount of great facilities there, Ascension Seton, Dell Children's, ARC, et cetera. And I looked at, within that preferred network, what does it cost to get an MRI? And Harlan, an MRI is an MRI. Unless the thing falls down on you, it's about the same level of care. There was an 8 times price difference between the top 10% cost MRI and the bottom 10% cost MRI. Now, what does that mean? People are overpaying by 8x because they went 2 blocks further away rather than having somebody they could really listen to. Let's take it back to the DPC. The beauty of having the DPC in the model is that if I was to call you, Harlan, and say, you're on our plan, I think you ought to go to this street corner to get your MRI. You'd say, how did you get my phone number? But if Dr. Ben Aiken calls you, if Dr. Chris Larson, if Monica McKetterick calls you, you're going to listen We know from running these plans for thousands of people for the last 7 years, people are going to go where their DPC tells them to go, and you can save the plan a ton of money. So that's, again, I'm coming back to that main thing. Everybody's going to know this soon. So if you're an advisor, you're listening to this, if you're a DPC that's listening to this, it's cheaper to put you at the heart of the plan. This is why I agree with my friend Marielle Concepcion when she says, in the long run, direct primary care will just be called primary care.
And that's what it should be. But because of the health system that we have now, that the majority of our primary care physicians are in, no one really knows what a primary care physician is. There's so many different looks at it. I mean, what do you hear people, and I know direct primary care has faced this some, and that is, oh, it's just a different kind of gatekeeper. Or it is, they're not even saying different, it's just a gatekeeper. So you're putting me in a plan that's got a gate. It's like an HMO. It couldn't be further from an HMO. An HMO does have a primary care physician you must see, but that person's only job is to spend 5 to 7 minutes with you and refer you to a specialist somewhere. They're not going to spend.
And Harlan, it's going to take you 38 days on average. That's a real number from KFF to go in and see them. I can bring this home to really make it personal. You know, my sons are 11, that's Boone, and 7, that's Ben. And Ben was 6 years old last year, and January 31st at 10:30 at night, he couldn't breathe. My wife, Anna, and I want to say happy birthday to Anna. It's Anna's birthday today, and she's definitely my better half. But, you know, Ben couldn't breathe, and it was the most afraid I've been in 44 years on this planet. And I did what I always do, Harlan. I called my dad, and I said, Dad, wake up. Your grandson can't breathe. Tell me what to do. That's a level of access that's spectacular. And when people have had DPC for a little bit, they don't think of it as a gatekeeper. They go, man, this is a doctor that I can text or I can call. Yeah. Now, less importantly, because decent's not as important as the direct primary care movement, it's a function of our plan that we don't make you see the DPC. If you want to call us, we can tell you where to go. If you want to use self-serve tools, you can do that too. It doesn't function like an HMO. But the access that you have to a clinician in a plan like this is incredible. Now, you and I both know that there are people with doctors in their families. When you have a doctor in your family, you don't look at ChatGPT, you don't look at Google, you're going to call that doctor. I have family members who will call each other because we got too many docs in my family. And I have friends that will call a veterinarian in their family and they'll say, hey, I know, but I know you handle birds, but look at my foot. We're so desperate for an expert. And that's really what we try to do, is offer that expert when we build the plan around direct primary care.
Yeah, you're exactly right. So there's a couple other things I want to touch on what you said right there. And that DPC, that's doing something, having a DPC doctor in the center of this thing is doing something that you may remember, depending on your age, from back in your childhood or your parents' childhood. You may have remember them talking about someone that they had built trust and rapport with, someone they actually had a relationship with. You still see it today outside of DPC, but only in small towns where they have still that same type of physician. But it's very rare to see that outside of DPC. It's in those situations.
I love that, Harlan. If I can riff with you a little bit on that. So something we think about at Decent, you know, people say everything old is new again. And for folks that are looking at this DPC movement and saying, oh, it's too different, you know, it couldn't possibly work. It's exactly what you said. I know this is the future of healthcare because this is the past of healthcare. This is the past. Before everything felt so broken. Now I'm going to tell a story, and it's a little off color, and you'll have to forgive me. So if you're listening and you're at work, then put your headphones in. I grew up on an island where my parents were the doctors on this small island community called Bainbridge Island, actually where Dr. Garrison Bliss, the founder of Direct Primary Care, lives. And I remember how awkward it was for me that my parents knew everybody on that island. They were the doctor for everybody on that island because I had a lot of friends that played sports. And every year around the same time, which was like the beginning of, you know, lacrosse, soccer, I'd have a handful of my friends that had come up. And I'm sorry to say this on your webinar, but, you know, they'd say, hey, Nick, your dad touched my balls yesterday. I remember I had to hear this every year growing up. Every year. Crazy. And I know it's inappropriate, and I'm sorry about that. My parents were the ones that would come in and they would give kind of the sex ed talks. But the point is, people knew each other, and your doctor would really know you to the point you could embarrass his poor young son. And I think that's what people miss. We've gotten so disconnected from each other, and we've gotten disconnected from our doctors. And then you look at this PPO system and you go, again, I could take all the drugs in the world, but I shouldn't do it without knowing what I'm doing. And you got to have that that quarterback. That's what we think the direct primary care doctor is. And I hear some people that are saying that they're the coach and maybe the patient's the quarterback. That could be true too, but the patients I know don't want to run their own plays. They want to be told, this is where you got to go to get the outcome you want.
Yeah. Robert Fiver had another grade. He says, I used to refer this as the Dr. Welby, Marcus Welby, MD, right? Strategy as soon as he's talking about, and no one knew what I was talking about. Well, there's some of us that would have known what you were talking about there, Robert, but maybe not as many younger people. Emma might not know. Emma might be too young to know who Marcus Welby was.
Probably.
But the other part that we see, and this is crazy, but 61% of Americans now don't go to the physician unless they're sick. Okay, so the early detection and prevention of so many things is kind of out the window when that happens, right? If all you're doing is reactive medicine, if all you're doing is sick care, then you're not in a place where you're being preventative, you're being proactive. And that's the other part of what direct primary care and navigation will help you do. And I want to separate those in a second. I know that all your plans are built around direct primary care, Nick, and that is very important. But if you are on a plan that is not built around direct primary care, but you do have quality navigation and your primary care physician is not, once again, they don't have to be direct primary care. It's a bonus, but maybe you're in a situation where it's close to the same thing, not exactly the same, but it's called advanced primary care. So they're still practicing a higher level of primary care, and they're making sure you get to quality physicians. You're still on the right pathway. I don't think that there is an absolute replacement for direct primary care. It's number one, but number 1D-ish is advanced primary care. It's not the same thing. It's right down the line from there. A lot of times you're not getting the same doctor every single time. You've got a team that's working with you, but they're still doing very holistic medicine, which is really, really awesome and where you need to be, because now
you're ahead of the game if you're doing that. And it's for a really simple math reason. The thing that is really, really broken in this country is this idea that you're supposed to do nothing. You never see a doctor. Despite everything we now know about the social determinants of health, just live your life unfettered by any medical opinion until the day you have a heart attack, and that's what your insurance is for. Like, what a terrible idea. I love direct primary care. I think this is the way. And I'm also a fan of everybody who is trying to do the same kind of stuff we're doing. They think of themselves as my competitors. I think of them as fellow adventurers and friends. I love the folks over at Taro Health that are building a fully insured plan around direct primary care. I love the folks over at Yuzu that are creating plans around direct primary care, virtuous benefits. I don't care about being the only one in this space. We won't be the only one in this space if it's the future. And so the point is, like Harlan said, more primary care is better. You need more of it. I was in a sports teams and I did wrestling, and then I've had plenty of time where I would just go to the gym and bust out a set. Sometimes I'd injure my arm or I hurt my back doing that fast as I could, just trying to get the exercise in. This is different. This feels like having a personal trainer for the first time that can sit down with you and go, okay, well, what are your goals? How is it going? What's holding you back? It's very, very different from I'm going to get in, I got 12 minutes, and then I got to get out. And I think I don't care whether you get it from Decent. I don't even really care if you get it from direct primary care versus the other models. You need more primary care in your life.
Absolutely, because another thing that's addressed in navigation, and this, remember, when you have the right kind of navigation too, this is the other part, is you've got to have a clinician, in my opinion, you've got to have a clinician that's doing the navigation, because they have to have a better understanding of the healthcare system and the things that could be going on, because you cannot have someone who is health illiterate guiding someone else who is health illiterate, because we have a huge problem with health literacy in this country. And so you need someone that's on their game, that understands what's going on and understands the system and understands the best advice. Because remember what we said earlier, folks, and that is each patient, no matter if they have the same exact condition as someone else, they have very special things about them that the navigator needs to know and understand, and they have to be able to ask the right questions. This is something we see even in primary care, when people don't have time for their doctor and they have no relationship with their doctor, They're simply not telling them everything that's going on. I had a conversation with someone this morning who was talking about the situation that they had a loved one in, where their primary care physician didn't even know they were seeing some of these other physicians for different ailments that they had decided they had. Everyone's giving them medications, and some of these medications do not interact well with each other, and they got themselves in a pretty serious medical issue because they're not sharing information. It's so disjointed. Now, this particular person, unfortunately, is on a Medicare plan. And if you don't know this, I'll tell you, if you are Medicare age and you qualify for Medicare in this country, you got Medicare, whether you want to or not. You don't have really any other options unless you happen to work for a large employer that allows you to stay on their plan. But once you retire, then you have to get Medicare anyway. So it's a tough situation for folks in that, but you still, outside of your plan, you still can get direct primary care to address a number of those things. This is turning into a direct primary care love fest here, and that wasn't necessarily my intention. But you know what? Hey, if the shoe fits, then you got to wear it.
It is. Let's talk about, because we don't just need to talk about direct primary care. It's about relationships. And actually, I want to take a step back from healthcare even. I'm a big nerd for two things related to research. I'm a nerd for happiness studies. I want to know what makes people tick and what makes them happy. And I'm a nerd for longevity studies. I want to not just have a happy life, but a long, happy life. So I look at those things. If you completely ignore healthcare, the single biggest predictor of the length of somebody's life is the strength of their relationships. And you really need to understand what's happening. Strong connections with other people give us something to live for. It's not even just about keeping, us alive for longer. Why wouldn't it be the case that having a strong relationship with a doctor, with a clinician who really knows you, is going to keep you alive? I mean, I want to live into this beautiful future that's starting to unfold in front of us. And even if Decent drop dead tomorrow, which we won't, we're really well capitalized, we're going to be around for a good long time, I would still be a direct primary care patient for the rest of my life. But exactly to your point, it's not just about DPC. You have to have somebody that knows what they're doing. I see Dr. Pfeiffer, Robert Pfeiffer, putting interesting things in the chat. You have to have experts in the system. It wouldn't make sense to try to find the best music in the world without some kind of a DJ. And it wouldn't make sense to try to find the best healthcare in the world without somebody that really understands, that can help you sort the wheat from the chaff.
Yeah, absolutely. And of course, Angela Dula over at AIM has also chimed in about agreeing that, clinicians are the key for triaging and making sure that each patient is guided to the best quality care for that particular patient. And that's of course what they do. AIM is a nurse navigation team, one of the best out there without a doubt.
And Harlan, I want to talk a little bit, if I can, about a friction that we intentionally introduced to the Decent model, because I think clinicians should be in charge. That's the bottom line for me. We had a hard decision to make early on as a company. I was just talking to my wonderful VP of product, Sandy Dato, about this morning. And we decided we're not going to employ the docs. And that doesn't mean that you couldn't do something great employing the docs. But we said, hey, we need to keep them arm's length enough that they really feel like they can take care of our members, and that's it. And if we start to pay their paychecks, we all have seen what happens in these systems. Right now, the Bucas are all buying up primary care. I was talking to my dear friend Clint Flanagan, who runs Nextera Health. I really admire Clint. He's been doing this for 15 years, never raised his rates as a DPC. And we got a little tipsy together, and I said, Clint, I see that all the Bucas are buying up primary care. Do I need to worry they're just going to buy you and this beautiful experiment will be sort of dead in the beginning? And he said no, and he laughed at me, and he said, Nick, do you have any idea how much I went against my own financial interests to start this thing? You really think I'm just going to sell to the Bucas now that it's working? And it helped me understand this is a movement in this community that is really trying to not just shoot for, can we make healthcare better for 5%? The goal here is to build a better future healthcare for America and potentially beyond.
So I want to address what you just said real quick there, because yes, we are seeing the Bucas and private equity and fill in the blank, health systems, whatever, buy up and suck up all the primary care. And we also see a number of these that have done this that have failed miserably, right? They went in this thing, I've told the story multiple times now about Walgreens decided to jump into this thing with Village MD, and so far they've lost about $6 billion. That's with a B, $6 billion. And in my opinion, and the opinion of a lot of folks out there, it's because they still don't get it. They still don't realize that it is not about just having a primary care accessible. It's about having a physician that has the time to build a relationship with someone. When you do nothing more than put the same 5 to 7 minute physician in the pharmacy so you can go in and out quicker, it doesn't fix anything. It doesn't fix healthcare. It doesn't fix primary care.
I want to talk about my mom for a minute. So my mom was my hero. Some of you know that already. She died a couple years ago, real unfortunate, and I miss her. And a lot of my motivation is to build something she'd be proud of. But, anybody who had Sarah Faulkner as their primary care doctor, they knew that they had one of the best doctors in the world. But she herself was limited by her incentives and her system. You could have a wonderful 12 minutes with my mother, and then based on the rules of Group Health Cooperative, and I'm not knocking them, this is another HMO, you had to go down the hall where she probably referred you to get meds. She probably referred you to a specialist because that's how HMOs make money. And as long as doctors are sort of tied to this system that is treating them like cogs in a machine, of course we're not going to get better health outcomes. What does it mean that the doctors themselves have the highest suicide rate of anybody in this country? What does it mean that my mother would come home and tell my sister and I, this is the worst time to become a doctor in the last 50 years? We have to fix that. There's this notion of clinician heal thyself, physician heal thyself. We got to get the doctors healthy and happy so they can take better care of the rest of us.
Yeah, we both just got home from the HINT conference. And one of the things I believe that really stands out about that conference, and I've noted it over the last few years as I've attended it, is you will never see a happier group of physicians.
Yeah.
So to your point of what you're talking about there, is your mom loved what she was doing. She loved it, and she loved to have the relationship. It was kind of limited, but she loved to have that. Well, These folks are back in their world. Man, they are so happy. Most of them have escaped the system. They were trapped in it for the longest time, and they finally just pulled the plug. But what was exciting about this one, Nick, and I know you saw it too, there were so many people, so many physicians there that were talking about when they're going to start their DPC practice in January and February, in the first quarter of next year. There was all of these folks there that are ready to step away, that are in the process of it, have already got contracts on buildings, and they're building out their place. They're doing all these things. It shows us that everything is going in the right direction. And folks, it's not just about these folks escaping the system. They're getting back to practicing medicine the way that they always dreamed that they would, and they're moving away from the moral bankruptcy that is caused to physicians by being part of the traditional health system. That fee-for-service just beat you up waiting to get paid, reimbursements, and every year they say you're worth less and less, which is another major problem in our healthcare system. Everything should be built around primary care, and it's the worst paying, least I don't know best. The government doesn't even realize how important it is. Every other healthcare system in the world that's a successful healthcare system is all built around primary care.
They're starting to, Harlan, and I want to talk about you for a minute because you've been talking about me and DPCs a lot. The other thing I noticed at that event was happy brokers. And I want to sing a love song to the broker for just a minute because I didn't really understand y'all and what y'all have to do until I decided, hey, if I'm going to sell through brokers, which is clearly the right answer, by the way, and if you think these people are going somewhere, they're not. This is trust. What you're doing is you're buying into a network of trust with people that are largely, for the most part, at the same percentage as doctors, the same percentage as tech guys. These are people that are trying to do the right thing. Now, for a broker, it's been rough out there. It's been getting squeezed for commissions by United Healthcare, kicked around by the Bucas that like to kind of act like you're a necessary evil. And then you got guys like I was maybe 10 years ago that are coming in going, wait a minute, I don't understand why we need these brokers. These people will spend hundreds of thousands of dollars on Facebook and call it cost of customer acquisition. But the notion that they should pay somebody a little bit for finding the right solution for a customer and building that human trust factor, totally wild to some of these people. Now, you're between a Skilla and a Charybdis here. So what do? What I saw at the Health Rosetta conference, I see you at the HINT conference. I'm always happy when you come up. And by the way, you're a sharp-dressed man, which I do appreciate. These are happy brokers because they found a way out. These are happy brokers that can go to their client. They can say, I've got something really different for you this year. They can say, I found a way to improve your coverage while also reducing your cost. And for most of the people that are out there selling, this is what you want. I get it. I've been you, man. If to make it real personal for a minute, I became a broker because I said, I got to know what these people are facing because otherwise I can't serve them. And immediately, a couple of my good friends I've known since high school, they looked at me a little different. They said, you're a broker now. Oh, you're selling now. And I said, nothing about me changed in the last 2 weeks, except I took a test and I passed that test, by the way. And now you're going to look at me funny. We need to embrace each other. And this is the thing that I see. I see Decent as having an opportunity to be a convener of the different people that need each other in this space. Because I want to tell you a nice little thing that just happened to me last week. There is a friend of mine who is a DPC out in Indiana, Jessica McCartan, and she and I had connected. I have a new friend who's a broker, Cameron, and we brought a new group. And I connected Cameron and Jessica, and I said, hey, why don't we have Jessica come drive 9 minutes to this employer, and she'll walk into their office, and she'll get to know them, and they'll leave, and she'll be the new doctor. And you know what? Cameron wrote an unsolicited email to me and Jessica. He said, I've never seen a meeting like that before. He brought in the DPC. The client was enamored. They immediately started saying, well, yeah, we want you for this, but could you do our pre-enrollment screenings? Could you maybe help with some work comp? This is a group of people that need each other, and they're finding each other at places like the Health Rosetta and the Hint Summit. To any DPC that wants to say brokers don't have a place, do you want to go out and be grinding the market like I know Harlan has to do to figure out who needs what and get it to them? To any broker that doesn't figure out how to make money on DPC, that's what our plan is for, by the way. But this is really a group of people that can serve each other so well, and we can build this future together. It can't be done by any one group. This is really building a movement takes all kinds.
Yeah, you're right. And I'm going to point out and call out and talk to some of the other folks that say they do what I do, in particular brokers that are out there that say, you know what? I would sell that thing with DPC, but I talked to that doctor and he said he wasn't going to pay me nothing if I sold that DPC. So, if I don't get paid, then I'm not going to do that. What? Have you lost your dadgum mind? I mean, okay, I get it to a certain degree. We got in this to make a living, but do you not realize what you're bringing to people? Do you not realize that you are going to see very positive financial results in the long run by incorporating and building a plan that you're never going to lose? This client's going to stay with you for forever because you brought them something nobody else is going to. And why would they leave you if you stay engaged with them and keep bringing them new stuff? It's just like the doctor. They are going to be so happy with the fact that you brought them true healthcare. You hear what I'm saying? True healthcare. I don't care what these other companies say. United Healthcare, guess what? They ain't got no healthcare. Guess what? You can't buy on healthcare.gov. You can't buy no healthcare. But what you can get healthcare from is a direct primary care membership and a health plan built around those with proper navigation. That's healthcare. And if you're a broker out there that has no idea what I'm talking about, call me, call Nick, call somebody who knows this so we can explain to you how this will change your life in such a positive way. Man, you'll sleep so good at night and you're going to help people in a way you never thought you could by just signing them up on a Buka plan.
I'm so glad you said that. And I want to call out something that an anonymous user said. Are the brokers happier because they're doing the right thing? Well, one, yes, they absolutely are happier. But Harlan, I read you as even a little cleverer than that. I think like I know, that this is the beginning of something really different and really special. Yeah. I didn't know if this was true 7 years ago. I thought, hey, there's this cool thing called direct primary care. Maybe we could build a plan around it. I now truly believe this is the future of healthcare. And I'll tell you what, when we run into groups that don't really favor their broker, when we run into groups that don't have a broker and they are out there too, you might think that we're going to sell those groups directly. We don't do that. We're going to bring them in and we're going to say, have you met Harlan? You need a broker. Because I'm not going to prove what I need to prove by selling dental and vision and handling mid-year enrollments. I'm going to be handing them to you. And you know what's about to happen, Harlan. I know you do because you and I have talked about it. You're about to be at the ground floor of a transformative movement in this healthcare system. I know Emma Fox is on that ground floor. I know David Contorno's on this ground floor. There are other people that may or may not be listening. This is where you want to be, y'all. and we're going to be feeding you. Hopefully you bring us business too, but we are starting to get calls from DPCs that go, I want something for my practice. I've been seeing this employer for the last 5 years, and I just figured out that I could put a plan around it. I will never be writing that plan directly unless they kick and scream and demand, oh, I couldn't possibly handle a broker. But the truth is, we want to find the 20% of brokers out there like you, Harlan, who already get DPC, good folks, and I want to feed you because we need you to grow this movement.
Yeah, you're exactly right. And our relationship, the kind of the way that we met, Chantal, of course, as she says, she hunted me down on this thing. But part of it was because she saw what we were doing at Eagle Care, which was we were already building things around direct primary care. We were just using medical cost sharing instead. But what we found out, if you're an empathetic broker and you understand your clients, you have to meet them where they are. So shoving down their throat what you're offering is not the answer. You have to have different answers. And, I told you, flat out, man, I've been trying to do what you have already done without even knowing that you had already done it. So whenever I found it, I'm like, oh, praise the Lord. Thank you so much for, getting me together with Nick here so that I would have that option for the people that are not ready to go, say, away from health insurance. They want insurance. I appreciate you
saying that, Harlan, but all I did was I fast forwarded some things that we were all going to figure out were true anyway. I need to make my plans affordable. And I'll tell you this because you might appreciate it as a guy that can sell. I used to talk about DPC to anybody who would listen as the thing about our plan, the only thing you need to know. And then I realized if you can't be cheaper or as cheap as what I got now, I'm probably not going to listen to you. Most of the time I'm going to go, nah. But what we figured out was how to get these stop loss folks to recognize the value that direct primary care brings. That was the coup, is to help them figure it out, because as soon as they saw it, they said, well, wow, we should want these in our plans. We'll be able to incentivize this with a low cost. And then it turns out DPC is the perfect answer to the second question. I'm going to sound a little cynical when I say this. People are going to say, how much does it cost? That's the first question. And the answer has to be lower than what you got. And then they say, well, if it's lower than what I got, how do I know it isn't crap? And then you say DPC. And that's when you make the sale, Harlan. That's how this happens.
But, it's interesting. We had a great conversation. I was on a panel with Emma, actually, at Health Benefits Nation here a couple of weeks ago. And there were a number of employers out there. And what I told them about looking for a broker is the first thing your broker has to know is how a health plan is built. If they have no idea how a health plan is built, it's because all they've ever done is sold off-the-shelf health plans. And it just so happened that sitting on the stage right in front of me was one of those big old speakers. I know you've seen them before, Nick, big speaker. And so I asked the audience, I said, does anyone know how this speaker works? Does anyone know what's inside of this speaker? We don't. We just know that it works. But is this speaker the right speaker for everyone in here? Who has room for this big old speaker, right? Who would want this? You would want a speaker that, even if you didn't know how it's built, you would want someone to build that speaker for you. If you got a pool, you want one of those that looks like a rock or something else, right? You want a customized speaker for you. Well, there's people out there that know how to build that speaker, and they're going to build it exactly to the specifications that work for you and exactly to do the task that you want it to do. So if you have a insurance consultant, advisor, broker, whatever you want to call them, that knows that and knows how to build it and ask you questions about you and your company and your employees and how do you want your plan built and what do you want to accomplish with your plan? How do you want to present healthcare? What do you want to do about your healthcare spend? If they're able to ask those questions and then actually give you solutions to meet those, you have found the right person. If they can't, you need to be on the hunt for the right person to do that.
I like how you put that. I'm going to add one thing to it. I'm not Pollyanna-ish. There are people out there in the tech world who you shouldn't trust. There are people out there in the medical world who you shouldn't trust. And there are some brokers out there who you shouldn't trust. And there's somebody who I'm thinking of who I had a tough interaction with recently, worked real hard to get a great quote for this group that we would love to serve. And I came back and I shared it. And the broker said, wow, this kicks the butt of the other thing I was looking at. And I said, great. In the back of my head, I thought, okay, I'm ready to make this sale. And he said, but why should I sell this when I'm going to make twice as much selling this other thing that's overpaying me. And I'm not going to name a number. I'm not going to name who it was, but there are people that are paying to play in this market. And usually it's a home market. Their plans are crap. And it was a really tough one because ultimately I understand this is a relationship between a broker and an employer. I don't have a problem with that. I don't even think that every group is the same difficulty to serve. And I think you should get paid. But the way that this was framed to me of, I could sell this all day long. They'd be so delighted if I offered it to them, but I don't want to just because of my own profit motive. That one frustrated me. And what's really difficult is any one of us could make a million choices in a day to support the system the way it is or to change it to what we want it to be. But you have to recognize your role in that system. And I think it has to be a balance. Guys like me and you don't get to do what we do if we can't bring up enough money to take care of our families. But when that becomes the main thing that you're worrying about and not the family and not the world and not the legacy you hope to leave, I think something is a little bit broken in the system.
Yeah, Vicky just said, made a comment, ethics. And that's exactly what that's about. So imagine in this individual's situation, if unbeknownst to him, they were talking to another broker that all of a sudden brought this solution to them. Right. And he ends up getting nothing. He got zero, in other words, instead of bringing in a solution that he would never lose. Because as we talked about earlier, once you bring in something like this and they start seeing the wonderful effects it has, not just on their bottom line, but on the health of their employees, the health and happiness of their employees, the impact that's going to have on their business on so many levels, that is what's going to keep you in that with that group for long term.
It's the beauty of the free market too. It's what you said. That's right. As long as I got options, and this is again the cool thing about direct primary care. I'm going to contrast this to the existing system. So in the existing system, all it's going to take you 38 days. Maybe the person you're going to see or not. An interesting tailwind for our business is that as people get older, they're used to this model, and most of them now go, nope, I don't have a primary care, or I don't know who that is. But you got that system, or you've got this system where the doctor, ignore Decent for a second. These are docs that are hung their own shingle. They're charging that 70 to 90 per month. You are very aware when you're an individual and you're paying somebody 70 to 90 per month, they better do the job. And what that means is their incentives are aligned to actually keep you healthy. Because if you're sick every single damn day, their model doesn't work. They're trying to see 300, 400 people. And if you're showing up every day, it's real hard. But also, if you suck as a doctor, because we talk about how healthcare sometimes sucks, sometimes doctors suck. And if you suck as a doctor in direct primary care, you get fired. People go somewhere else. They vote with their feet. And I think that's how it should be.
I agree. Let's get back on navigation for a second while we kind of wrap this up. And then we'll take a few questions if anyone has them out there. So you can go ahead and start putting those in the comments if you have any questions. But one of the things that I hear over and over, no matter where I'm talking to people out in the country, especially for individual policies, and I get it, that is different than the group plans we're talking about, is can I get one of those PPOs? I want a PPO so I don't have to get a referral. I can go see a specialist if I want to. Well, I want you to think about what that means. Let's think about what it means to the plan. Let's think about what it means to you as an individual. You've probably diagnosed yourself on Dr. Google. You're probably now have some type of cancer that you're going to die from any moment now. So you want to go and see this doctor. And the main reason people are want this and so they can skip is what you said earlier, the 38-day wait that they would have to, the minimum of 38-day wait they would have to get to see a primary care doctor to say it's okay to go see this other doctor. Now, if that wasn't there, they would most likely go and see a primary care doctor first because that's where they should start. But the system, now the way it's designed, doesn't allow for that. We wipe that out. When you have a plan built around direct primary care and care navigation, not an HMO, folks, care navigation, all of those barriers are removed. And in an awesome plan like a Decent plan, the financial barriers are as well. Remember, that's a beautiful thing. It's a tiered plan where if you will follow the navigation, you have zero out of pocket. If you choose to go where you want to instead, then your deductible will apply. Those type plans are awesome because, as you and I talked about, it's the old carrot and the stick, right? Well, The carrot, if there is not a big enough stick, the carrot really don't matter, right? The carrot, who cares about that carrot? I don't really like carrots anyway. And so, but I will take that carrot if that stick's big enough. But It's amazing what free healthcare, free quality healthcare will do. that's a pretty daggum big carrot. I don't even need a stick then.
It's a good carrot. Now, I want to talk about the stick for a second because it's really interesting. We were really careful about where we set that non-preferred deductible because we didn't want to punish people. At the end of the day, it's about getting the behavior you want without anybody feeling left out in the cold. There could be a real crappy version of a decent plan out there where we go, and if you don't pick DPC at the start, we're going to charge you up the ear no matter what. And we don't do that. We say, hey, we know that it's someone, and it might be the CFO's wife as an example, that's going to say, hey, I really like my primary care doctor. I'm not comfortable switching. In fact, as an aside, if you've got an existing relationship with a pediatrician or an OBGYN, we always honor that and treat that as preferred. Not only can you keep seeing them, but that costs you $0. But back to that primary care doc. I'm not going to be telling somebody, oh, you have to believe what I believe. I don't work that way. If you want to keep your primary care doctor, you keep that primary care doctor. Our deductible is $3,000, which is middle. You know, that's actually lower than some of the plans that we compete against for their preferred. Yep. But what might happen is you might say, hey, I'm going to keep that primary care doctor. And then 1 month into your care, you have a care need. And you're going to say, because this always happens, oh, it's going to take me 38 days to get in and see this doctor. What was that thing Harlan was talking about? What was that direct primary care? You're in there the same day or the next day. And I swear to God, Harlan, you are never going back. And so we try to, my mother used to say, you know, you catch more bees with honey than vinegar. The goal is to make DPC really stand out as a great solution because we know once you try it, you're not going back.
Yeah, that's right.
I have a question from Dory that says,
yeah,
not really free if they're paying for it, right? And that's true. If somebody's paying for it in the bottom of the plan, then yeah, you wouldn't call that free. Probably more accurate to call it $0 out of pocket for the member. You're not paying anything more. You're absolutely right, Dory, that part of the cost of what you're paying on an underlying basis is baked in. But think about what must be true from a math perspective for me to be able to afford to make the thing that we want you to do, that your doc wants you to do, that you want to do, totally $0 out of pocket, because it's so much more affordable than doing the thing that you might not want to do, like going to a large private equity-backed urgent care center every time you get a nosebleed. So absolutely, it's true that it's not free to everybody, but we can make these things so much more affordable for people than they are now. And actually, that takes me back to some conversations we had with some DPCs. There are some real hardliner, libertarian wing DPC party out there that'll go, I don't even understand why there ought to be insurance. And my gentle response to those people is, you've never had cancer. And we all don't want to be hoping to not be the one that gets cancer. And usually they'll begrudgingly go, okay, well, I think you could pay for it in a better way. Well, great. I hope we can, because that ought to happen. But there's nothing evil about the notion of insurance. What's, I think, evil is the notion of enriching these gigantic insurance companies by pushing you to have coverage you don't need for things that you ought to be able to get through your primary care doctor. And that's what we try to do.
No, and you're 100% right there. The analogy's been used and probably overused that when we buy auto insurance, we don't buy our auto insurance for oil changes, filters, things like that. But when we buy our health insurance, we do. We buy it so we can have co-pays for this and co-pays for that. Well, you also have that opportunity when you buy your vehicle. It's kind of funny. So think about this. When you buy your vehicle, you can pay a little bit extra that then gets paid out over the entire time to take care of all of your maintenance. So you know you have zero out of pocket for your entire maintenance all the way through the time that you have it. Well, DPC is very similar to that if you want to think about it, in that if you want those type of services, you want to make sure your car stays at the peak performance and there's no monetary barriers for you to go and get it checked out. Well, now you got it because it's already there and it's zero out of pocket when you can go have those things done. So it's not exactly the same, folks. I'm not trying to say it is, but that's kind of the mentality I have when people say, direct primary care, because now we get back to sick care. Then I don't need to go unless I'm really sick. Well, you're going to get really more sick if you don't go.
Harlan, I understand that we're not here just to talk about direct primary care, and I am a bit of a hammer that sees nails in things, but the point is, don't go it alone. The point is that if you want to support the system as it is, that overcharges people, where healthcare is the leading cause of bankruptcy in this country, where the average deductible on a family plan is $5,000, where the only people that are really getting rich are the biggest BUCAs and hospital systems, then by all means, get your PPO plan, go wherever you feel like, and understand that you're perpetuating a model that's going to make it even more expensive for your children and for your children's children. And I'm not really trying to shame here. The truth is, people don't mostly know how this works. But if you want to try something a little different, And if you want to be able to have expert guidance to get you to the care you need, not the care that Blue Cross wants you to have, then I think that this is a model. There are other models too. The number one thing is find people you can trust. Don't go it alone. Find a broker like Harlan. Find a broker like Kelly. Find a broker like Emma who will actually care about you and make sure you've got options. Find a doctor, or if you can't find a doctor, find an incredible clinician like my friend Monica McKetterick, who's a DPC out of Texas, and work with them. But we've broken so many things in this country by telling everybody that the ultimate value of freedom means that you go without information to do whatever you want. That's what's making our system bleed the way that it is.
Yeah, absolutely. Well said, Nick. Navigation really, folks, is the key. Our opinion, if you haven't gathered that already, is the great place for that navigation to start is direct primary care. But remember, navigation should be started definitely with a clinician. It should be to high quality providers. If this person cannot give you, whoever's navigating you, even if you have Blue Cross, if you have United, whoever it is, if you have someone that there is saying they're navigating you and they cannot give you the quality scores of the physicians that they're sending you to, you're getting the wrong kind of navigation. I won't spoil it for you if you have one of those kind of plans. I'll let you try to get those numbers and see what they give you. But I will tell you that is one of the paramount things that you have to have, is you have to know you're getting quality, and a good navigator is going to lead you to quality. And if you ask, well, how do you, when you ask that question, well, how do I know this is a quality doctor? They'll have the answer.
And you know what? It's bonus points. It really is. If they're a clinician, that helps. Doesn't matter if they're a doctor, doesn't matter if they're a nurse practitioner, traditional RN nurse. Clinicians can talk to each other. Nobody wants to admit this, but they talk in a different language than you and I. And the best care happens when one clinician goes to another and says, hey, this is my guy right here. This is my woman right here. And I want you to help her out, because they know how to talk to each other and get that care that people need. We should not be at the whim of Google ChatGPT hallucinations to figure out where to go to get our care.
Absolutely. That's another thing I think that was pointed out very strongly at that HINT conference when we saw these physicians that were talking about the relationships that they have with one another and the networks and friendships as they've built to help one another out. And I'll tell you what's great and very, very inspiring to see is we have more specialty physicians that are coming in too, that are supporting now the direct primary care movement. So we're seeing more direct specialty care, and we're also seeing a lot of those specialty care doctors supporting their brethren in the direct primary care because they love what they're seeing from them.
I love that, man. And to be really honest with you, I just had this conversation with Garrison Bliss. He's very humble. He's a humble man. And he, was sort of saying, well, there's DPC and then there'll be whatever comes after DPC. And I said, sure, I'm sure that's right. That's how movements change. But I don't think that it's possible to create an ideal healthcare model that doesn't start and lean hard on primary care. I know how much things cost. I've seen the math. That part is probably never going to change. So whatever else you see in the market, it might be called advanced primary care, might be called direct primary care, schmarek primary care. It doesn't matter. If you want to take good care of people, it starts the way it always did. It starts the way it did for my grandparents. You got to have a doctor that knows you and your family. That's the bottom line.
Absolutely. Thank you so very much, Nick. We really appreciate I'm going to be very respectful of your time and everyone else's time. Try to keep this thing to the hour that we said it was going to be. Folks, personalized care, that is the bottom line here. Through navigation, through your primary care, whatever that looks like, personalized care is what's going to set things apart. It's going to give people true access to care. It's going to break down those barriers. And hey, it's going to improve the outcomes. And that's what it's all about, right? Improve those outcomes, keep yourself healthier. That's the big deal there. All right. Once again, I'll touch on, we will have our next event on the 31st of October, Halloween. That's right. We're going to do another healthcare horror stories. It will be an audio only event so folks can jump up on stage and share their stories with us. Thank you so much for being with us. Nick, thank you so much for taking time out of your busy day. Man, I know you're wore out, and we got a heck of a fourth quarter coming up, brother. I appreciate you.
I got a ways to go, man. I don't tire too easy. Thank you, everybody, for listening, and talk to y'all soon.
All right, everyone take care. We'll catch you next time on Why Does Healthcare Suck? We are out of here.
Bye-bye.